Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time, but note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, the role of the pathologist in the management of the pituitary patient, is being presented by Dr. Sylvia Asa. Dr. Asa is an endocrine pathologist and professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. A clinician-scientist with a focus on endocrine pathology, her research aims to identify the basis for development of neuroendocrine tumors, to improve diagnostic tests, and to identify targets for therapy of those diseases. She has published over 450 scientific articles, written 5 books, co-edited 5 books, and contributed to more than 100 book chapters on endocrine pathology. She serves on numerous editorial boards of scientific journals and has given over 275 invited lectures. Dr. Asa was president of the Endocrine Pathology Society from 1997 to 1998 and the US-Canadian Academy of Pathology from 2005 to 2006. She has received many awards from national and international scientific organizations. As head of the largest pathology department in Canada for 15 years, Dr. Asa made innovative changes to the practice of the discipline with emphasis on subspecialization, molecular diagnostics, biobanking, automation, pathology informatics, and digital pathology. She has emphasized the importance of education and research to ensure public knowledge of the role of pathology and maintain a direct connection with patients. Dr. Asa is a consultant to several patient groups, including the Pituitary Network Association. We are going to change presenters, and there will be a brief delay as we do that. And Dr. Asa, you should see the prompt to accept on your end and show your screen. I can see your screen.
Thank you so much, Tammy, and welcome to everybody on the webinar today. As Tammy said, my discussion today is going to be on the role of the pathologist in the management of the pituitary patient. And I do have a couple of quick slides I just need to go through. I have a few disclosures to make. I am involved in some efforts to digitize pathology, which I think will benefit the discipline. And I just wanted to review the goals and objectives of what I'd like to go over today, and that is to understand the scope and the role of pathology, to appreciate the clinical importance of the classification of pituitary tumors and other pituitary diseases that are done by pathologists, and to be familiar just very briefly with some of the molecular testing and its applications for determination of genetic predisposition and also treatment of diseases. So as you've heard, I'm a pathologist, and it's not very often that patients specifically will get a talk given by pathologists, because traditionally pathologists have been kind of considered the doctor's consultant rather than a patient's consultant. Part of that is historical, and part of it is just the nature of what we do, and I want to briefly just review for you what pathology is. And it basically comes, the terminology comes from Greek words, the word pathos, which means feeling or suffering, and the word logia, which is the study of. And basically pathology grew from a discipline of studying the diagnosis of disease, which evolved over many years by looking at organs of patients, tissues, body fluids, and even whole bodies from autopsy, for example. So the goal of pathology is to arrive at the right diagnosis for a patient, to help establish what the prognosis of that patient is, what's the likely outcome, what's the pace of disease likely to be, and also to do some prediction, which is how to treat the patient. Pathologists learn enough about disease that we can tell clinicians this is likely to respond to drug X or Y. Some of what I'm talking about here, and I'll point out that in all of my slides at the bottom, I have in italics citations, because some of the slides or the parts of slides come from either other publications or other places, and this particular slide comes from a YouTube that, if any of you are interested in watching, really talks about what pathology is all about. The origins of pathology go long back to ancient Egypt and Greece, where mostly at autopsy, scientists who were interested in why people died tried to study the body to understand the cause of death and to explain why the patient had specific signs and symptoms of disease. But pathology really came to the fore in the 1900s when many of the things that were being done for investigation started to have clinical application. So, for example, people who had studied parts of organs or cells or little pieces of tissue started to recognize that when a surgeon removed tissue from a patient, we could study that tissue and try and understand more about the disease. Laboratory hematology grew out of hematologists who studied the blood of their patients who had blood disorders. And biochemistry really was the baby of nephrology and endocrinology, because people started realizing that we could take blood and urine and analyze it with biochemical tests to understand when hormones were not working right or when the kidney was not working right. And of course, in infectious diseases, microbiology became the way to study what organism was causing an infection in the patient. So today, pathology is actually we could say it's a very big business. It's actually a very important part of medicine, because pathologists provide all the laboratory-based clinical testing. So, for example, what you're seeing on the right is a photograph of the biochemistry and hematology lab at the University Health Network in Toronto, where we do automated biochemistry and hematology analysis for bloods and urines, where we have a huge operation, as do almost every hospital and all private labs, that really is focused on primarily automated testing for biochemistry, hematology, microbiology, and pathology has become really the home of understanding quality control and quality assurance. There's a phrase called good laboratory practice, GLP, which applies to how we run laboratories in ways that we can assure accuracy of all of those diagnostic tests. There's another very large part of pathology, which is microscope-based anatomical pathology, and that's what I'm going to focus on more today. And of course, pathologists represent the custodians of samples on behalf of patients, because we get all of the samples. We don't keep everything, but we ensure that what we've collected is from the right patient, that the tests go back to the right patient, the results go back properly. And of course, in some cases, we do retain samples for a very long period of time to ensure that a patient has what is required to go back if there are questions about their results. And pathologists tend to be the representative of patients when we're dealing with quality of care events, such as morbidity and mortality rounds, because unlike many of the other clinicians, we stand by very quietly and don't get actively involved in treatment. Now, one of the sadder parts of pathology is that because we're so busy in our labs, many pathologists do not have the opportunity to get into contact with their patients. And I know many of you that I've spoken to in the past, because I do a lot of communication with patients, really are not aware of their pathologist. Some don't even know who their pathologist is. And to me, that's a problem, because you should have a relationship where you understand who is the person that made your diagnosis. Because ultimately, the pathology diagnosis is the gold standard that indicates the presence or absence of disease, the type of disease and its classification, and every therapeutic decision is based on a pathology diagnosis. And of course, we've seen examples where a misdiagnosis can result in unnecessary, harmful, aggressive therapy or inadequate treatment. And these are all scenarios where pathologists may have made an error, where there may be some differences of opinion about different diagnostic criteria. But in every case, it's of value for the patient to know who their pathologist is, what the pathologist has said, and what it means to them in their journey through their treatment plan. So just for the rest of the talk today, I'm going to concentrate entirely on the pituitary patient. And I need to remind you that for everyone who's a pituitary patient, you all know that you have biochemistry done frequently, because that's how we measure your circulating hormones that are all dependent on the pituitary, which is really the master of the endocrine orchestra, the conductor. So you're all getting biochemical tests done by various labs. But for those of you who've ever had pituitary surgery, you'll know that you've had a pathologist who's characterized your pituitary pathology. And that's what the rest of this talk is going to be about, because I would like to help you understand your pituitary gland and what went wrong with it or what might be wrong with it, and how we can investigate further so that we can better understand how to treat patients like you. So I'm going to start with some basic images that will help you just to grasp what the pituitary looks like. Many people don't have a chance to actually see this because this is what pathologists do, and you don't usually talk to pathologists. But in this slide, you'll see a drawing which shows basically the brain up at the top and the pituitary gland, which hangs by its stalk from the hypothalamus, which is the base of the brain. And the pituitary has three parts. There's an anterior lobe, a middle lobe, and a posterior lobe. And the posterior lobe is an extension of the brain. And here at the top right is a photograph of a real pituitary taken at autopsy from a patient who had no abnormality in their gland. This is a perfectly normal pituitary showing exactly what's in the illustration, but in real life. This is the pituitary stalk hanging from the brain where it's been detached. You can see it's been cut here. The posterior lobe is at the back. You can see a very small residual intermediate lobe cleft, and the anterior pituitary, which is the bulk of the gland that makes most of the hormones that we talk about as pituitary hormones. Here's another photograph of another gland and an illustration showing a different perspective. If we just go back to this one, you're basically looking at a person's pituitary from the side of their head. Imagine you're looking through somebody's ear into their head. This is the perspective that you would have. In this picture, it's a different perspective. Imagine if you cut off the top of their head and look down at the pituitary from above. The pituitary has been cut in half horizontally. This is the posterior lobe here and the anterior lobe at the front. And here's the intermediate lobe with the little clefts that are residua from embryologic development. And in the schema, you can see that the gland actually is very well structured. The posterior lobe is responsible for secretion of specific brain hormones called vasopressin and oxytocin. And the anterior lobe has 5 different cell types. At least 3 of them are distributed in a very characteristic geographic pattern. The cells that make growth hormone, those that make prolactin, and those that make ACTH. Now, the pituitary makes many hormones. And as we've learned, and by the late 90s, we recognized already that the pituitary is actually a very complex tissue. It does derive from a single stem cell, presumably, but there are 3 very specific pathways of cell differentiation that give rise to different cell types, each of which is responsible for making a specific hormone. So, for example, corticotrophs make ACTH, somatotrophs make growth hormone, lactotrophs make prolactin, thyrotrophs make TSH, and gonadotrophs make FSH and LH, the gonadotropic hormones. So you know, if you're a pituitary patient, you may or may not have an abnormality in which you may have too much ACTH, which stimulates the adrenals to make too much glucocorticoids. If you have acromegaly, you might have too much growth hormone. If you have a prolactinoma, you would have too much prolactin. All of these different hormones are involved in regulating different parts of the body in different ways. I'm not going to review that in great detail today because I wouldn't have time. That's a subject on its own. But I do want to point out that our diagnosis of pituitary pathology depends very heavily on recognizing the different cells that we're studying. And until the late 90s, we depended specifically on looking at these hormones that are on this slide. But since that time, we've also recognized that we have additional biomarkers that are very interesting. These are transcription factors that regulate the differentiation of each of these cells, so that whether the cell is making hormones or not, whether it's active or not, we still can recognize what a cell looks like based on its transcription factor pattern. So I'm just giving you this background so that you'll be able to follow through the rest of the talk how a pathologist evaluates the cells that are in a biopsy and whether they're normal or not, whether the distribution is right, whether the cell is differentiated enough to make hormones, or if it only expresses transcription factors. These are all parameters that pathologists use to try and understand diseases of the pituitary. Now, I can't spend a lot of time on hypopituitarism because it can be due to many different causes, and many patients who have hypopituitarism never have a pathology sample sent to a pathologist like me, because many of those problems, such as genetic abnormalities that arise that during development fail to develop cell types, or sometimes patients have inflammatory or vascular problems that result in death of pituitary cells. Those are not always operated on surgically, and we rely on biochemistry to help us understand what are the abnormalities in terms of pituitary function. If there's an infectious cause, we do microbiology to understand that. And in general, patients who are hypopituitary get hormone replacement at physiological levels that depend on their age and their gender and their size and many other things. And as a pathologist, I'm involved, of course, in the biochemical monitoring, but I don't usually do tissue analysis of patients who have hypopituitarism, unless it's caused by something else. And that something else is listed on this slide, which is very busy. And I would not expect us to be able to go through all of these different things today, because in an hour we couldn't possibly cover them all. But I do want to emphasize that there are many different kinds of tumors that can arise in the pituitary, and these are called primary neoplasms. There are tumors that involve the pituitary from tissues around the pituitary, like the brain or the brain coverings, and so you can get things like meningiomas or gliomas in the pituitary. Sometimes patients who have a tumor somewhere else, a cancer of the breast or the colon, may have spread to the pituitary through the bloodstream. The pituitary is very rich with hormones and growth factors that tumors love, so they often do spread to the pituitary when people have very bad cancers. But mostly what I want to concentrate on today are the primary tumors of the pituitary, and I will also mention very briefly some hyperplastic lesions, as well as a few inflammatory lesions that can involve the pituitary. And at the end, I'll just make a couple of comments about some other things. But mostly what I want to concentrate on are the unique tumors of the pituitary. And by far and away, the vast majority are what we call pituitary adenomas. But before we start talking about those, I want to bring to your attention a proposal for change in terminology of these tumors to be called Pituitary Neuroendocrine Tumors. And I'm going to talk about that in a little bit more detail in a moment. Now, why would I want to be interested in this field? As a pathologist, I spent over 30 years studying pituitary tumors, and some people say, why do you spend so much time on something that's so rare? Well, pituitary disease has been considered rare in the past, but on this slide, I'm providing you with some references for studies that have shown that, in fact, it's not as rare as it used to be thought. And this was all precipitated actually by the PNA, which I have to give a lot of credit to Mr. Bob Knutson, who encouraged us back in the early 2000s to review all of the published literature on the incidence of pituitary tumors, because we knew that from some autopsy studies actually, incidental pituitary tumors were found at autopsy far more commonly than they were ever diagnosed when the patient was alive. And so we did this meta-analysis that showed that actually 17% of the population might have a pituitary tumor. And that prompted a number of subsequent studies, which are all listed here from different countries where they have reliable databases, showing that pituitary tumors have a prevalence of about 1 in 1,000 in the general population. So they are not those rare zebras that we need to be watching out for. They're actually very common. Now, this terminology change that I mentioned was prompted by a meeting of a group of people who are very interested in pituitary pathology. At the very bottom, you can see the International Pituitary Pathology Club. We've recognized for a long time that these tumors are members of the family of neuroendocrine tumors. And neuroendocrine tumors occur in the thyroid, in the parathyroid, in the pancreas. They occur in the gut and in the lung. These are all members of a family of cells that make peptide hormones, which is exactly what every cell type that's hormone secreting in the pituitary is. It happens to be a gland composed entirely of neuroendocrine cells, which is why we never really thought of it in the context of other neuroendocrine tumors that occur mainly, for example, in the gut, where that's not the primary function of the gut, but there happen to be neuroendocrine cells there. The WHO, the World Health Organization, has recently come up with a proposal, which I've cited, this is a paper that's still in press, to establish a common classification framework and terminology for neuroendocrine neoplasms at every site in the body. So actually this Pituitary Pathology Club proposal from 2016 antedated what the WHO is trying to do to change terminology from adenoma to neuroendocrine tumor. But our rationale was actually a little bit different. We weren't thinking of trying to keep these aligned with other sites. We were actually trying to make the point that the behavior of pituitary tumors is variable and unpredictable, as it is with other neuroendocrine tumors. And the terminology of adenoma, we thought, was doing a disservice to patients who often were getting brushed off saying, well, you have a tumor, but it's benign, don't worry about it, when in fact, these patients were having a lot of morbidity that, you know, doesn't really correspond to just a benign tumor, because first of all, it can invade into the brain and into structures around the sella. It's not easy to remove, as some of you will know, surgically. And the hormone secretion wreaks havoc on patients. And so it's not just a simple thing that can be safely ignored as a, quotes, benign tumor. So we thought it would give a little bit more respect to pituitary patients if their tumors were classified as neuroendocrine tumors, just like the ones at other sites. And so now we have the support of the WHO for this change in terminology. It's not being applied in many places, but I would encourage you to bring this to the attention of your caregivers. The spectrum of pituitary tumors is very large, and I just am showing you a few examples on this slide of a tiny microtumor that might be small, hormonally inactive, and might represent just an incidental finding that was picked up when the patient had an MRI for headaches or something else. Here is a much larger tumor that's invading into the cavernous sinuses of a patient who has a clinical disease, and in this case may also have had hormone excess, which in fact they did. And here is a giant pituitary tumor that's very locally invasive into the brain and even blocking the flow of cerebrospinal fluid that can cause what we call hydrocephalus in a patient. So these tumors can be very small, slow growing, and incidental. They can be huge tumors that can kill a patient. They can be somewhere in between. But I want to point out that even these small ones can be very nasty. And here is the pathologist's perspective of what those tumors look like. And I'm showing you one of these tiny microtumors here. This is an autopsy specimen, a pituitary that was removed from a patient who unfortunately refused treatment, but she had very florid Cushing disease. So these tiny tumors may be incidental findings, but they may also be the cause of something very significant. And if you know anyone who's had Cushing disease, you will know that this is a very significant health problem. On the right is a view of the skull of a patient. This is an autopsy photograph, and I apologize if it makes anyone feel uneasy or queasy. You can look away for a moment. But this is a huge pituitary tumor that's bursting out of the sella turcica of this patient who had no ante-mortem diagnosis of the pituitary tumor. No one understood why he was becoming a bit forgetful and having trouble with his thought processes, and it turned out that he had a non-functioning but very large pituitary tumor. So this spectrum is huge, and the damage that it can do to patients is enormous, which is why I support the PNA in their efforts to bring awareness to people about this disease, because it is so incredibly common and we don't know it, and people are not thinking of pituitary. So now let's talk about how tumors are classified, and if you see an endocrinologist, your endocrinologist is going to tell you whether your pituitary tumor is functional or not, and if it's functional, is it making, for example, growth hormone and you have acromegaly, or is it Cushing's, or do you have a prolactinoma or a non-functioning tumor? If you see a radiologist or a neurosurgeon, they will classify your tumor as on a structural basis. Is it invasive? Can it be resected surgically? Is it recurrent or residual postoperative? How fast is it growing on serial imaging studies? If you're a pathologist, you're going to classify the pieces of tissue that you get from the neurosurgeon based on their histology, their immunohistochemistry, which is a way of looking at protein and, for example, hormone and transcription factor content of a tumor cell, and on their ultrastructural appearance if you have access to very high magnification using electron microscopy. The best way to classify tumors is a clinical pathological correlation, which includes all of those: functional status, structure, and morphology. And I would argue that we also should be classifying tumors based on their responsiveness to drugs, so that we can actually predict which drug to give a patient and determine whether they're responding appropriately or not. Now, I'm not going to talk much about pituitary carcinoma. This is the only slide I have that includes the word. It's exceptionally rare. I have to tell you, I've seen well over 3,000 pituitary tumors in my career, and I've only seen 7 or 8 that were classified as malignant or carcinoma. And that's because the definition of carcinoma restricts it to a tumor where there is spread beyond the pituitary, either into the rest of the brain and spinal cord or to other tissues like lymph nodes, lung, liver, or bone. And that does not happen. Fortunately, it's exceptionally rare in pituitary tumors. But that doesn't mean that these tumors cannot create havoc by invading locally around the sella turcica, where the pituitary is, and by causing hormonal abnormalities that cause damage to the patient. So what I'd like to do now in the second half of this webinar is to review some of the diseases and what the pathologist does to help clinicians understand what the disease is and how to treat it. And I'm going to try to emphasize for you that what clinicians call functional classifications and what surgeons call structural classifications are very simplistic. And actually, morphologic classifications have allowed us to recognize that many pituitary diseases are not one disease. There are actually many different diseases that can be distinguished morphologically, and it probably matters, and we have evidence that it matters in some of them. So let me show you a few examples. This is a patient who gave me permission to use photographs of her. She was young, she was in her late teens, and you can see on the left what she looked like when she came to her doctor. She had florid Cushing's disease. You can see she's got the typical moon facies. You can't really see her buffalo hump, but you can kind of imagine. She's got terrible acne. Her face is very red and discolored. She has, if you were to see her whole body, she had central obesity. This is a girl who had very high glucocorticoids because she had a pituitary tumor. And the picture on the right is her after successful surgical resection of her tumor, showing what a dramatic difference a good surgeon can make in the life of the patient. And this girl fortunately remains cured many years postoperatively. Now, her disease is classic Cushing disease. That's what Harvey Cushing described in the early 1900s. And her tumor looked like this tumor on the left. It was actually a very tiny tumor. It was hard even to see on imaging. At that time, we relied much more on inferior petrosal sinus sampling to know where the surgeon had to go in the pituitary to find this little tiny tumor that caused this horrible disease and was able to be resected. Now, there are other patients who have a very different kind of tumor. And they actually have tumors that look different to the pathologist. The one on the left has a lot more color in it. The one on the right has less color, so we call it chromophobic. It's afraid of color. And this was actually a much larger tumor, and the patient presented with Cushing's, but it was not so florid. He was an older man, and he had a much larger tumor that was very easy to see on MRI. And basically, the pathologist can distinguish between these two different kinds of tumors that we call basophilic or densely granulated chromophilic tumors, as opposed to the chromophobic or what we call sparsely granulated tumors. And in our experience, and we have a lot of experience in Toronto, as I said, I've seen over 3,000 pituitaries. In my experience, patients who have big Cushing's, like really florid symptoms, generally have a small tumor that is one of these basophilic, densely granulated tumors. Whereas patients who have big tumors and very small or subtle Cushing's have one of the chromophobic tumors. And actually, it's interesting because some people don't even pick up the diagnosis of Cushing's when patients have this tumor on the right, and it's called a non-functioning tumor. And when they do immunostains and they find ACTH, they call it a silent corticotroph tumor. That's not really always true. I like to call these whispering tumors because a good clinician will ask the right questions and find out that the patient did have some evidence of Cushing disease. And when they do the biochemistry, they'll find it. And when we operate on the patient and remove the tumor, the patient is cured, if we can get the tumor out. So there is a big difference between these two, and there may be some differences in the behavior because we've recently identified that there are some mutations called USP8 mutations that tend to be found based on preliminary data, granted so far, in these small microtumors, and these probably respond very well to some of the somatostatin analogs, whereas the larger ones probably do not. Now, the other important thing in pituitary Cushing's is because the tumors can be very small, we sometimes don't get them in the pathology specimen. And we have a difficult diagnosis to make then because the pathologist cannot diagnose Cushing's on the tumor. But the important thing that the pathologist should look at is the non-tumorous pituitary, because it has a change in patients who have true Cushing's disease. The non-tumorous gland has a change which we call Crooks-Hyland change, which is shown on these pictures. For those of you who aren't pathologists, it's irrelevant, and I won't go into the details. I use this picture to teach pathology trainees as well. But the important distinction is that if there is Crooks-Hyland change, you know the patient really did have Cushing, and that it's not a case of pseudo-Cushing, which is often in the differential diagnosis. And if there is a tumor and you see this change in the non-tumorous gland, you're quite confident that there's no hyperplasia associated with it, whereas if this change is not present, that does not bode well for the patient because it's very likely to have recurrence. Now, that Crooks-Hyland change is also really interesting. This is a very rare entity, and it's probably not relevant to most of you, but there are occasional patients who have cyclical or atypical Cushing disease who sometimes have tumors like these two that are composed entirely of these suppressed Crooks cells that can look very odd and very dangerous, and sometimes this is misdiagnosed as metastatic cancer. So a good pathologist has to know what to look for. Now, what I've told you about Cushing's is kind of early days, but in acromegaly, we've known that acromegaly is not one disease for a very long time. And here you can see two patients, one of whom has very florid acromegaly with severe disfigurement, and another one who you might not think when you look at this person sitting on the bus that he or she would have acromegaly because the changes are not nearly as florid. But both of these patients have a pituitary tumor. And their pituitary tumors are of two different kinds. And again, we've come to understand that growth hormones producing tumors actually come in many different varieties. The two most common are what we call, again, like in Cushing's, densely granulated versus sparsely granulated. And it's interesting to me that the best biomarker of this difference is not even growth hormone, it's actually a part of the cytoskeleton that we call keratin. Keratin is what's in your skin, but keratin is in every epithelial cell. And for pathologists, I always tell them that when you have a tumor, a pituitary tumor from a patient who has acromegaly, if you could only do one stain, the most important stain to do is a keratin stain, because it will show you either this pattern, which is kind of a uniform, pale, kind of random distribution of keratin filaments, as opposed to this pattern where you see these very beautifully defined balls of keratin that are the hallmark of the sparsely granulated growth hormone cell tumor. Now you're going to say, well, I have acromegaly, who cares which kind of tumor it is? Well, there's a very important difference between these two. The densely granulated tumors, first of all, tend to be plurihormonal. So they also will produce alpha subunit. They may or may not produce prolactin and be classified as mammosomatotrope tumors. But this keratin pattern, irrespective of whether there's just growth hormone or multiple hormones, this keratin pattern predicts a tumor that's very likely to have a mutation in what we call the GNAS gene, which is a gene that signals through the growth hormone releasing hormone receptor, resulting in high cyclic AMP, which is kind of the energy of the cell, and which is the perfect target for somatostatin. And patients who have these tumors, if the tumor cannot be resected completely by the neurosurgeon, patients who have these tumors generally do very well on long-acting somatostatin analog therapy. Now, that's not the case in sparsely granulated somatotrope tumors. They don't have high cyclic AMP. They often will have mutations either in the AIP gene, or they have epigenetic silencing of AIP, or maybe something involved in growth hormone signaling on its autoregulation. In any case, these tumors tend to be far less responsive to somatostatin therapy, and probably much safer to be treated with the growth hormone antagonist pegmidizumab. There's one other point I want to make, that many patients who have these tumors have actually been misdiagnosed, because these tumors tend to be very weakly positive or negative for growth hormone staining. Here I'm showing you a few cells that are positive, but sometimes the whole thing looks kind of like maybe a non-specific background stain that a non-expert would say, well, I can't really call this a growth hormone tumor. And then when they're misdiagnosed as non-functioning tumors, the patients have far less obvious acromegaly, like I showed in the first slide, and they may not be diagnosed properly or treated properly for all the complications of acromegaly. Now, I want to be complete, but I don't have time to spend on too many of the rare entities. There are other rare causes of acromegaly and gigantism, including congenital abnormalities, hyperplasia because of ectopic production by other neuroendocrine tumors of growth hormone releasing hormone, and very rare hypothalamic tumors that can make the pituitary overactive, resulting in acromegaly and gigantism. So the pathologist, as you can see, has a very important role to play. First of all, if it does happen to be a hyperplasia that's removed at pituitary surgery, the pathologist is the one who should be putting up their hand right away and saying this patient should be investigated for something somewhere else, like their lungs or their pancreas or somewhere else where there might be something else going on. But in even regular cases of acromegaly, the important distinction by keratin between a densely and a sparsely granulated tumor should help to guide the treatment for patients. And then, of course, if there's prolactin in a growth hormone secreting tumor, that raises the possibility that the patients may actually respond to dopaminergic agents, not just somatostatin. Now, patients who have hyperprolactinemia have a much larger differential diagnosis, which includes pituitary neuroendocrine tumors that make prolactin, but there are many other things that can be involved. And I just want to remind you that anything on that long list of tumors that occur in the region of the pituitary can cause destruction of the pituitary in a way that interferes with the inhibitory flow of dopamine from the hypothalamus, resulting in elevation of prolactin because of excess secretion by normal prolactin-producing cells in the pituitary. So when a patient has hyperprolactinemia, we always have to think about any of these other reasons why there might be a tumor there, and that becomes important in how we approach the treatment, because many of these will not respond to dopamine agonist therapy, which is how we usually treat prolactin-producing tumors. I also want to remind you that there is inflammatory disease involving the pituitary in some patients, and this lymphocytic hypophysitis is one type that is particularly common in young women and often associated with pregnancy. And it's very important for clinicians to think about this in the differential diagnosis. In fact, if you have a very good radiologist, they should be able to make the diagnosis that this is not a tumor, it's a hyperplastic or inflammatory process. They can tell that on radiology, and patients who have this should not undergo surgery. They should be treated without surgical resection. If a patient does have a tumor that's producing prolactin, again, there are two different kinds of pure lactotroph tumors. In this case, the sparsely granulated tumor has a very characteristic pattern of prolactin positivity, only in the little machine called the Golgi complex that's making prolactin and not stored in the rest of the cytoplasm. These are the more common type of tumors, and these usually respond very well to dopamine agonist therapy. In fact, we hardly ever see these at surgery because most of the time they're treated medically. The tumors that don't respond tend to be more aggressive, like this densely granulated tumor, which is a very different beast morphologically. And I always like to remind patients and doctors that patients who have the typical prolactinoma should have a tumor size that's directly proportional to their prolactin levels. Otherwise, there's a problem. This is not going to be a typical lactotroph tumor. Don't expect it to respond appropriately to dopamine agonist therapy. And one of the examples that we often see is this unusual oncocytic kind of tumor that is made up of what look like lactotrophs, but they're not normal lactotrophs. They're not sparsely granulated. These tumors tend to have a very unusual pattern of downward invasion rather than upward invasion into the brain. They tend to come down into the sinuses, and they tend not to be responsive to dopamine agonist therapy. They're usually large when the prolactin levels are high, but not as high as they should be for a large tumor. So again, for the pathologist's involvement in your care, the classification of the kind of lesion that you have in your pituitary is very important in determining whether or not you should be treated with dopaminergic agents. Is there a role for radiotherapy in the treatment of a patient who's got an unresectable tumor? These are all things that need to be considered based on tumor type. Now, patients who have TSH excess are very rare. There are thyrotroph tumors. I won't spend time talking about them. They're much easier to classify. The important messages are that these tend to be invasive lesions. They're often not surgically resectable, and they often need somatostatin therapy and possibly radiotherapy. But one of the saddest experiences I have, and I do get it periodically on average once a year or every 2 years, is a patient who actually has a tumor removed from their pituitary, and it's called a thyrotroph tumor clinically, and then the pathologist gets it and they see that there are all different kinds of cells, and they classify it as a plurihormonal tumor because every hormone is positive when they do their immunohistochemistry. And actually, there's a very simple stain called the reticulin stain, which I'm showing here, that tells me that this is not a tumor. This is what we call thyrotroph hyperplasia. These patients usually have primary thyroid disease. Their thyroid does not work. The pituitary responds by growing and stimulating and working overtime. And these patients should never have surgery. They should have been treated with thyroid hormone replacement, and their pituitary would be intact. Sadly, these patients do still occasionally undergo surgery. But again, the pathologist plays an important role in directing care from here on and saying, no, the pituitary is not the problem, treat the thyroid. Now I'm going to finish with a discussion of non-functioning pituitary tumors, which are actually very common. They usually present when they're large because they don't produce too much hormone initially, and they only come to our attention when the patients start to complain of visual field disturbances, headaches. By that time, they are hypogonad, they've got low growth hormones, sometimes they even have lost their thyroid and adrenal function. It's a very late presentation of disease. But again, clinically, this may be one group of tumor. To the pathologist, there are many, many different kinds of tumors that can cause this disease, including growth hormone secreting tumors that are silent, true silent lactotroph or thyrotroph tumors, the category of silent corticotroph tumors, which we know are very aggressive tumors. The vast majority, however, are silent gonadotroph tumors. And as a pathologist, we can use our stains for transcription factors and hormones to tell exactly which kind of tumor this is. The majority being silent gonadotroph tumors are usually quite indolent, and we can find in those tumors positivity for steroidogenic factor 1, sometimes a little bit of FSH or LH, some alpha subunit. Most importantly is the SF1, which we find in almost every one of these silent gonadotroph tumors, and we can reassure the patient and the clinician that this tumor will be indolent and grow slowly and tend not to be terribly aggressive. The silent corticotroph tumors are much more aggressive, and the null cell tumors, which used to be thought to be very common before we had specific transcription factor immunohistochemistry, we now know that these are actually far more rare, and real tumors that are classified as null cell are much more aggressive tumors. And this is data just from 2015 from Japanese colleagues. I would encourage you to remember this and to talk to your pathologist if you've had the diagnosis of a null cell tumor. We recently published a series of 1,100 pituitary tumors that have been characterized using all of the modern tools. And you can see here that null cell tumors are less than 5% of pituitary tumors, whereas the bulk of the clinically silent tumors are actually gonadotroph tumors. So if your pathologist is doing the job well and classifying tumors properly, you're going to know whether you have a slow indolent tumor or one that's likely to be more aggressive. These fancy tools have allowed us to also better classify some unusual tumors that may be clinically silent, like poorly differentiated tumors of PIT1 lineage that are also somewhat more aggressive than your ordinary silent gonadotroph tumor. Now that brings me to the topic of prediction of growth or prognosis, and we do use a number of biomarkers in pathology to determine how fast tumors are proliferating. Many of you will have a pathology report with a Ki67 or MIB1 index label, but I have to emphasize, and we reviewed in this journal, article that sometimes very large tumors have very low proliferation rates. And this is actually a very tiny tumor. This was from a teenage girl who had Cushing's, and her tumor was less than 1 centimeter, and yet look how much Ki67 there is. It's proliferating very rapidly. So we have issues with what is the most reliable way to predict tumor growth, and that's especially true when we look at how people analyze these data. If you have questions, I'm happy to answer them about that subject a little more. For me, the most important thing that I like to tell patients is that invasion is really the most important predictor. If you have a tumor that the surgeon can remove surgically, your prognosis will be very good. If you have a large tumor that is invading into places where neurosurgeons cannot go to remove it, if you cannot resect it, you cannot cure it. And that's where the pathology starts to become important in terms of determining how that residual tumor will be treated, whether it will be somatostatin analogs, dopamine agents, dopaminergic agents, or will it be radiotherapy. So I'm going to finish now with just a couple of very brief comments because I want to leave time for questions. There are some other very unusual tumors that occur as primary pituitary tumors, including craniopharyngiomas and some tumors of the hypothalamus and posterior pituitary. The craniopharyngiomas are the ones you probably know best, and we've made a little bit of progress in the last few years, recognizing that there are 2 different morphologic variants. And you can see anybody looking at these slides can recognize the difference between this papillary craniopharyngioma and this adamantinomatous one. And we know now that there are completely different genetic abnormalities underlying these. The papillary tumors have BRAF mutations, whereas the adamantinomatous ones have beta-catenin mutations. And that means something because if you have a BRAF mutation, there is a drug available now which can be used to treat residual tumor that cannot be resected. So it's important to know the kind of craniopharyngioma that you have to be able to predict whether or not this drug can be used. There's a small group of patients who have unusual tumors that arise from the cells of the posterior pituitary. For many years, this was a diagnostic dilemma. Some of the research that we did back in 2012 and 13 with some of our colleagues has now proved that these are actually the structural cells of the posterior pituitary gland that give rise to these unusual tumors that have been called spindle cell oncocytoma, granular cell tumor, and pituocytoma. We now advocate just calling them all pituocytomas, recognizing what they are. And then very recently, we had a series of patients with an even more unusual syndrome due to excess production of vasopressin by the posterior pituitary. These are exceptionally rare tumors called neurocytomas, And of course, I mentioned earlier gangliocytomas that are neural tumors. I mentioned them in the context of acromegaly, but they can also be associated with Cushing disease. So these are exceptionally rare, very unusual tumors. I don't want to spend time now on them because I'd rather have questions from you. But I hope that I've helped to help you understand that your pathologist is a very important player in the management of pituitary disease and in helping clinicians, both endocrinologists, neurosurgeons, and oncologists, to understand exactly what kind of disease the patient has that will help them to tailor the therapy appropriately, specifically for you as a patient. So on that note, I'm going to stop, and I'd be happy to answer any questions that have come up over the course of my talk.
Okay, thank you so much. That was fascinating. We have several questions. First is a two-part question. I have a 3.7 millimeter growth identified initially as an adenoma affecting the TSH and ACTH, causing cyclical Cushing. No one seems to be able to tell me much here in New Mexico. Is it operable or not is the first question, and would it need to take the entire pituitary out? Thank you. And then the second part of that question, in addition, how can one tell if it's adenoma, Rathke's, cleft cyst, germinoma, or any other type of tumor? I had a gallium-68, which did not show any other endocrine type tumors and did not light up with the pituitary. I do have 3 MRIs identifying a growth. I also had 9 of 14. Midnight saliva cortisol test extremely high. My endo wants to send me to NIH, Stanford, or UCLA.
So it's very hard for any physician to give specific advice to any given individual. From what I gather from your comments, it sounds to me like you do have a tumor that is producing excess ACTH. Exactly whether or not it should be operated will depend on many other parameters, but I'd be happy to share my email address, which is Sylvia, Sylvia, .asa, at utoronto.ca. And I'd be happy to help individually to give you some advice on how you can proceed. I'd need a little bit more information.
Okay, thank you. I've been diagnosed with acromegaly. I have had tissue in my breast that affects my acromegaly. I have recently had a bilateral mastectomy, and my surgeon stated when she removed the tissue it involved tissue of a type she had never seen previously. My surgeon did not know where to send this tissue, and the local pathologist stated this was above his scope. Do you ever look at breast tissue? And since my tissue was stored in formalin, is it still viable for testing?
So let me start with the end of the question first, and that is that any tissue that is stored in formalin is viable. It remains something that can be examined. Formalin is a preservative that keeps tissue kind of permanently. Most of the time, the tissue is then embedded in paraffin, and if you remember, I did show a picture of a small block of tissue, and if you go to the WebEx that I cited, you'll understand better how that works. But having tissue available that's formalin fixed and embedded in paraffin means that it's available for any second opinion or subsequent analysis down the road. So the good news for you is that if there is breast tissue that's unusual, it's been preserved in a way that's probably going to make it available for a very good breast pathologist to review it. I do not examine breast tissue because breast is very different from endocrine tissues. I can certainly, again, if you would like to email me, depending on where you're located, I can help you find a very good breast pathologist who could give you a second opinion. But just going back to your pituitary story, if you have acromegaly with breast disease, I have to say I've seen a number of patients who have hyperprolactinemia who develop a very characteristic breast disorder called gynecomastia, and that may well be what you have, and it suggests to me that your tumor must have been producing some prolactin at some point. And the questions, again, I'm happy to help you individually. If your hormone secretion is rectified, then this should not recur, but it would be interesting for you, of course, to understand if that's what you actually had. So gynecomastia would be the diagnosis I'd be concerned about, and we can work together to find a breast pathologist who can help you do that.
Excellent, thank you. Is there evidence that any PitNETs, other than the ones with congenital in their name, are congenital?
Oh, that's a great question. Most pituitary tumors are not thought to be congenital. We don't know when they start. Obviously, we only know when we diagnose them. But based on, for example, autopsy studies of children who die for other reasons, there's no evidence to suggest that pituitary tumors are even rare findings in patients who die early in life. There is no question that they increase with age. There is a lot of data to suggest that some types of pituitary tumors seem to be enhanced at the time of puberty. So congenital abnormalities are exceptionally rare. And I did mention on my slide one of them, the X-lag disease. Other than that, there's very little to suggest congenital abnormalities, except one other very rare disease, which is not a PitNET, it's called a pituitary blastoma, that again is a genetically related tumor that occurs in very young children.
Thank you. This comment is from the first question we had. I guess you answered my questions and then some. Wow, thank you. I still have many questions, but what I can see, I have a tumor that is non-surgical. I have a question then. The Gamma knife or other similar possibility?
So for patients who have pituitary tumors that are not operable, there are many different approaches that can be used. One of them is Gamma knife. I vaguely remember you saying something about a 3-centimeter tumor, and I may be wrong because it's been a few minutes now and a few questions in between. Gamma knife is very good for very small bulk of tumor. Once you get into something large, Gamma knife is not really the best treatment. So there may be other forms of external beam radiation that can be used. But in many centers, and this is something, again, I'm happy to talk about in email conversations or even a telephone call, large tumors still can be debulked surgically. Even if the resection is not going to be curative, the ability of debulking a large tumor and leaving behind a smaller amount of tumor that could be targeted by something like Gamma knife is one approach that is used in a lot of centers. So this is something that really must be tailored based on many different parameters.
Okay, thank you. Can empty sella develop into a tumor?
Great question. Empty sella is a congenital abnormality that allows fluid to accumulate in the pituitary fossa. The volume and the pressure of the fluid makes the pituitary gland get compressed up against the bone, so it looks like the sella is empty, but usually the pituitary is there. Most patients with empty sella do not have terrible dysfunction of their pituitary, although it can cause some hypopituitarism or hyperprolactinemia. But of course, as with anything, having a pituitary gland can develop a tumor, and the pituitary is there. So there are definitely examples of patients who have empty sella and then develop a pituitary tumor in their empty sella. So having one does not exclude the other in any way.
Okay, thank you. First, thank you for a deep dive into pathology, and I really appreciate the images you included. With regard to MRI of the pituitary, is it, in your opinion, why is it common for a pituitary patient to receive a report stating that the pituitary and its structures appear to be normal when they are not? Is it simply a lack of training in knowing what to look for?
So it's a very complicated question that you're asking, a very good question. Sometimes we have to remember the limitations of technology and, of course, the limitations of individuals. So depending on how the MRI is done, and there are many different ways of doing MRIs, pituitary glands can look normal when there really is an abnormality in the gland, and that may be because either the contrast wasn't used or the wrong contrast was used or the different weighting of the images was not appreciated properly, and sometimes even MRIs are done as serial sections, and the sections just may not get the spot in the pituitary where a lesion is. So, and of course, there's always the opportunity that the person reading the MRI doesn't really know as much as they could know about this, and part of that is experience. But in any case, if somebody has clear evidence of a pituitary abnormality and they have a normal MRI, usually we ask for a repeat examination at some point, maybe give a bit of time because there might be something growing that isn't detectable yet. Or if the quality of the examination left something to be desired, we can repeat the MRI sooner. But this is where having people who know the clinical and radiological features and have really a very deep understanding of pituitary disease need to be involved in multidisciplinary discussions with the patient about what all the possible explanations are.
Okay, thank you. Is BRAF V60E, another question of spelling, effective with silent giant PitNETs, and can it replace radiotherapy for non-operable tumors?
So BRAF V600E mutation is a very common mutation in many cancers. In the pituitary, so far as we know, it does not occur in PitNETs. It does not occur in any other tumor type except papillary craniopharyngiomas. The only other exception to that would be metastatic diseases in the pituitary, like a melanoma that might have that mutation, or a thyroid cancer, or a colon cancer. But generally speaking, primary pituitary disease, the only one known to have BRAF V600E is the papillary craniopharyngioma type. And so that would be the only indication for BRAF targeted therapy.
Okay, thank you. Could a GH-producing hormone, clinical, biochemical, and pathologically confirmed, recur after gross total surgery with no evidence of biochemical raising in GH and IGF-1, but potential evidence of any regrowth at MRI? Thank you.
So when I was a medical student, I had a very wise professor who always told me that you never say never. Anything is possible. However, generally speaking, patients who've had surgery for a growth hormone secreting tumor, who have no residual disease on imaging, and whose growth hormone and IGF-1 have normalized based on the newest standards for determining normalization, tend to do very well. Now, as I said, we never say never. Tumors of the pituitary tend to be reasonably well delineated, and a neurosurgeon can usually see the tumor and take it out. And most neurosurgeons are able to take a rim of normal gland around it to ensure that it's all out. But we also know that these tumors do grow by infiltrating the normal gland, and it's always possible that a few cells are left behind, and even having a few cells of tumor left behind, you can have a temporary normalization of growth hormone and IGF-1, and then it can recur. I have seen that scenario, but generally speaking, that's the exception, not the rule. Most patients who normalize postoperatively and have a persistent normalization for a year tend to do very well.
Thank you. With a prolactinoma and they want to treat with medication, how would they figure out what type tumor it is to know what medication will work best?
That's a really great question. So I wish we had a better tool to allow us to do pathology without sticking something into your pituitary to get a few cells. What we have to rely on is the dynamics of the tumor size, the prolactin level, and the rest of the pituitary function. So in a patient who has normal pituitary function and a tumor with a prolactin level that fits the size of the tumor, so, you know, for example, if you've got an 8mm tumor and a prolactin of 400 or 500, then that's kind of okay. But if you have a 3cm tumor with a prolactin of 500, that's not okay. We can sometimes predict that this is going to be a typical sparsely granulated lactotroph tumor that's likely to respond to dopamine agonist treatment. And the real answer is that what we do is we try and we see. If you have a typical lactotroph tumor and your prolactin level is proportional to tumor size, you're likely to respond. We give treatment. It's kind of a diagnostic test as well. If the prolactin level falls and the tumor starts to shrink, we know that's what it was. If the prolactin level falls and the tumor doesn't shrink, then it's not likely to be a lactotroph tumor that's going to respond, and we can get hormone control, but we may not get growth control. That tells us it's probably a different kind of tumor that ultimately may end up requiring surgery.
that over the time, as we age and our pituitary gland levels start to drop due to age, that medications will or can be decreased or stopped due to no more production of function of our pituitary gland?
So that's a wonderful question, and it's a huge topic, and I can't really answer it in great detail, but I can tell you that yes, the pituitary is a very dynamic organ. Pituitary function is dynamic physiologically. Everything changes throughout life. When you're a kid, you need lots of growth hormone. When you get older, you don't need so much. When you're in stress, you need lots of ACTH, and when you're very relaxed, you don't. The pituitary is a master of dynamic response to the environment. And so everything that we do to try to replace what the normal pituitary does has to be equally dynamic and responsive, which we all know is almost impossible, but a good endocrinologist will do their best to ensure that you are able to manage pituitary hormone replacement appropriately for your age, size, activity level, any other physiological and pathological changes that you may have to go through.
Thank you. I have had 3 surgeries for a non-functioning pituitary tumor. Was discovered when it hemorrhaged. First surgery was botched, and I was told I would have to radiate it. I refused, sought out a new surgeon who did a wonderful job of getting it removed. Had yearly follow-up MRIs, however, skipped in 2009, and in 2010, MRI discovered full tumor growth that had advanced into my cavernous sinus. Previous surgeon removed it, stated he had progressed further into the sinus area than thought possible. Yearly MRIs have shown no reoccurrence. However, my new endo doctor said they are not necessary. I disagree and question why he would say they are not still necessary.
So again, specifics, I need a lot more detail to give you a very clear answer. And again, I'm happy if you want to email me and give me more details. I would question what the pathology was in your case just to be absolutely sure, because that will make a very big difference. A clinically non-functioning tumor can be anything from a gonadotroph to a silent corticotroph, and depending on the classification and a little more detail about your progression, I'd want to know that before I gave any specific comments.
Okay, excellent. That concludes our question. Oh, no, wait, there's more. 5 years ago, I was diagnosed with Cushing disease and had surgery to remove a macroadenoma. 3 years later, my daughter was diagnosed with a oligodendroglioma. These are totally different types of tumors, but is there any evidence of hereditary predisposition or environmental exposures to developing brain tumors?
So that's a that's $1 million question. I wish I knew the answer. I am not aware of any specific genetic predisposition to those 2 specific diseases. There are genetic predispositions to each individual disease separately, but as I said, I'm not aware of anything that would unify both of them. That being said, again, there are some potential multi-tumor syndromes that every day we're starting to discover relationships between, you know, things that we never thought were related before. And I'll give you an example, which I don't think is relevant to you, but just is a relatively common one. There's a disease called Lynch syndrome, which is due to mismatch repair gene defects. And it's a very common cause of colon cancer. And I now have a number of patients, and there's been at least 1 report of patients with that syndrome having pituitary tumors. So my answer to you is, based on just you and your daughter, is that enough to justify concern? I would doubt it. But if there's more of a family history and there's more behind it, we are starting to recognize much more genetic predisposition to many diseases. So it's a good discussion to have. And again, I'd be happy if you want to email me, or if you would like to visit a genetic oncology center where there are many experts who are interested in this now.
Excellent, thank you.
So Tammy, just before you finish, I'll repeat again, anybody who wants to send me questions, Sylvia, Sylvia, .asa, A-S-A, at UToronto, for the University of Toronto, utoronto.ca. please send me questions. I prefer to answer individual cases on an individual basis.
Excellent, thank you. I was going to ask you to repeat that. One more question here. MEN, a sister had a schwannoma. I have a PIT. Another sister just passed and had questions about a prolactinoma.
So multiple endocrine neoplasia is becoming more and more widely recognized. It's a very well-established syndrome of multiple endocrine tumors. Patients with MEN do get other tumor types, including meningiomas. I can't recall if I've seen schwannoma, but certainly other tumors that are not endocrine can be part of the syndrome. As I said in answer to the previous question, there are many genetic predisposition syndromes, not just MEN, that are involved with pituitary specifically. And so any family where there's 2 or more tumors, it's worth asking the question and having testing done. I must comment that genetic testing for multiple endocrine neoplasia is great when it's positive, but not very helpful because many of the mutations are not detected on genetic testing. But there are other tools that can be used using immunohistochemistry if there's tissue from a tumor. And again, I'm happy to answer a specific question if someone wants to email me about that.
Thank you so much. This has been fascinating, very informative. We appreciate you taking the time, Dr. Asa. And
it's been a pleasure.
Excellent information. This concludes today's webinar presentation. We appreciate all of you taking the time to join us. If you missed any part of this webinar, or if you'd like to share it with family or friends, or just go back and review some of it, it will be available on our website after it is edited and converted. There's going to be a brief survey that you'll receive after it's over. And please fill it out and help us give you the information that you need. A bunch of thank yous coming through for you, Dr. Asa. We appreciate, again, your time and your valuable information. Everybody have a great day, and thank you for joining us.